welcome to tonight's final workshop. I am Dr. Sandy from All Star Family Chiropractic, and today we have guest speakers, Amy and Stacey, who are occupational therapists. That tonight we're going to be working on building the pelvic floor. So I'm going to take a back seat, but here's my ask, is that there are no ordinary moments. You are here because it's not by accident. You are here to open your mind, to open your heart, so that we can learn something. And when we learn something, we must learn to apply it in order to be useful of our time. Because when you give time in one area, you are giving up time somewhere else. So choose to be open to learn something new so that we can apply it and live a better life for ourselves and our loved ones. So please give a warm welcome to our guest speakers tonight, and I'll let them introduce what they do.
Thanks for the very warm welcome. All right, so I'm Amy and this is Stacey, and we are both pelvic health therapists, and we have a company called Health Elevated, where we are really passionate about sharing and educating people about what is the pelvic floor, what does it do, where does it live, and what happens when it's not working the way it should. Because we feel like a lot of women and men struggle with pelvic floor health concerns, but don't know how to get help or how to talk about it. So that's what we're going to talk about today.
Absolutely. So pelvic floor dysfunction, it can look like incontinence, it can look like pelvic pain or pressure. If you've been diagnosed with a prolapse, that's a form of pelvic floor dysfunction. But even some things that sometimes people don't think about, painful intercourse. Obviously there can be multiple causes of that, but one possible cause of painful intercourse is pelvic floor dysfunction. And constipation is another one that it's very multifactorial. There's multiple different causes, but pelvic floor dysfunction can limit your body's ability to evacuate the bowels fully, which can then lead into that constipation cycle.
Right.
Everyone has a pelvic floor. Sometimes people don't know that. Everybody has a pelvic floor, male, female, no matter what, you have a pelvic floor. So it's really something that everyone should have at least some understanding of. And it's just not something that's ever talked about. We don't talk about what is normal for bowel and bladder. We don't talk about, what is normal postpartum or during pregnancy. And so that's really kind of our big goal, is to just kind of shout from the rooftops about all things pelvic health related until everybody kind of knows. And then that way they know when to ask the question. I think the latest statistics show that some women will wait 8 years or more of being incontinent before they will even mention the symptom to their physicians. Because part of it is embarrassment for some people, but also part of it is just like that idea that, oh, you had a baby, so you leak now, so that's normal.
Right.
So we want to kind of change the script on that and say that just because it's common doesn't mean that it's just acceptable and that there's nothing you can do about it.
Right. So when it comes to bladder habits, what's normal versus what's common can often be a big difference. So what's normal is going to the bathroom every 3 to 4 hours. So this is for your bladder, for peeing. You should be able to hold your urine for 3 to 4 hours during the day, and about twice as long as that during the night. So from about the age of 5 to 65, you should not wake up at night to go pee. You should be able to go through the whole night, because what happens is that if you're going about every 3 to 4 hours, I see some shocked faces.
It's
Sorry,
true.
This is why what common versus normal. So what's typical with bladder habits is that if you're able to go about 3 to 4 hours during the day, you should be able to go twice as long as that
6 to 8 hours of sleeping
at night.
And part of that is when you are getting quality sleep, when you are actually getting into your REM sleep cycles, your body releases an antidiuretic hormone. Antidiuretic just meaning that it slows down your kidney's production of urine. Now, if you have sleep apnea, if you have poor sleep cycles or poor sleep hygiene, and you're not getting into those REM cycles, your body's probably not producing those sufficient levels of that antidiuretic hormone. So if you are producing daytime levels of urine, then you are going to still feel like you need to go every 3 to 4 hours. So again, is it a pelvic floor issue, or is it actually a breathing issue? And that is where, even if you're a pelvic floor specialist, you have to zoom out and look at the entire person and kind of get all of their history with that.
Yeah, we certainly just don't treat a pelvis.
And so then with the every 3 to 4 hours during the day, that should be without like this crazy strong urge. You should get a nice gentle urge when your bladder's about half full, just enough to kind of say, hey, something's going on here. When you get a chance, I might need to empty. And then substantially like smaller urges that are going to slightly increase in intensity as you go until that bladder's actually full enough that you need to urinate. But if you're just hanging out doing your thing and then getting like a random really strong urge where you feel like you need to go right now, that is part of that pelvic floor dysfunction as well. A really common trigger with that is that key and lock urgency, which is, you know, they've done some research and they find that it's a really common pattern for people to come home from being at work or running errands or whatever and immediately go to the bathroom. And they do that for years and years and years, and then it almost gets switched where now they're pulling in the driveway and before they can get to their door, they are leaking. So your bladder is very easily trainable in both good habits and bad.
So that kind of leads us into, like, there are different types of incontinence. So what Stacey just described is called urge incontinence. So that is that brain-bladder connection where your bladder is telling your brain what's going on, not the other way around. And that's when you have those very strong urges that make you need to go right away. And with urge incontinence, you're more likely to see kind of like a flooding. So you're going to lose a lot of urine because of that very strong urge.
Because the bladder's actually purposely squeezing and emptying because it's decided that it's time to go, whether it is or not.
And it doesn't matter how many Kegels you do and how strong your pelvic floor is, that urge incontinence is not going to improve with Kegels. Or Kegels. Anyway, but we'll get into Kegels.
Yes.
There's a whole other conversation. With stress incontinence, that is more related to a pressure system, which is why we're kind of hanging on to these very fancy, fun props. So with our pressure system, you can see our pelvic floor doesn't live in isolation. So just as a really quick introduction, our pelvic floor is a group of muscles that live in between, so if you feel them, those are the bony points that you sit in, your pubic bone at the front and your tailbone at the back. And that is, they kind of sling back and forth and they wrap around our urethra, our vagina, and our rectum. So that's why like peeing and pooping go together, because those muscles wrap around. There's 3 layers and 3 passages. So the first layer's job is for continence. And the second layer is get into more of that like control and what Stacey touched on a little bit with like painful intercourse. It can be related to those second and third layers of muscles. But when we have stress incontinence, it's related to that pressure system. So our pelvic floor is at the bottom and our diaphragm is at the top, all right? And they work together. Then we have our abdominal muscles at the front and our back muscles. And they work all as part of one system. So if you're having stress incontinence, it's because that pressure system, you might be getting like coughing or sneezing, which is too much downward pressure. Or say if you're very conscious of your midsection and you tend to grip or kind of like...
Or when you go to lift something and you've been told your entire life to really strongly brace your abs and hold your breath first, and then you leak.
Yeah, it's because of that downward pressure. So that's that kind of like that system is not working together. And typically it's not because of your pelvic floor muscles being weak, it's because they're holding too much tension. So they have no way to absorb that shock coming from above. Or say like jumping, so coming from above would be like coughing, sneezing, like you said, bracing. And then from below, think about like jumping, you know, trampolines, like jumping jacks, any of those activities that you might notice that you leak just little drops or spurts. And that's because of a pressure system problem. So that we would treat differently. That's when we start to get into more of that pelvic floor relaxation. So actually being able to connect with and find your pelvic floor, and we do that usually through breathing. So we want to be able to coordinate that diaphragm with our pelvic floor. So when we take a nice deep inhale, we inhale and our rib cage expands and our diaphragm moves down and our pelvic floor actually relaxes with it. So if you're taking a nice deep inhale, you should feel a really subtle sensation in your pelvic floor. So in between those sit bones, in between that pubic bone. And when you exhale, you should feel that kind of gradually and kind of relaxing back up to that starting position. And our Kegel is what happens on the exhale. So when we inhale, everything relaxes and moves down. And when we exhale, that's actually when those muscles start to come back up into that kind of like more tension. but we don't want them always to be in tension because then they have nowhere to go. So if we're always gripping with our pelvic floor and then we try to tighten it by doing a Kegel, and usually when people do a Kegel, they squeeze their butt, they squeeze their abs, they squeeze everything.
Everything all around the area, yes.
And nothing happens in those pelvic floor muscles. So that's, again, increasing tension but not targeting. So that's why so many women are like, I'm doing 50 million Kegels a day and I'm still leaking, I still have painful sex, like why is this not getting better? And that's why, because you're doing a lot of work but not targeting the core issue, which could be finding those pelvic floor muscles, because they're small and we don't talk about them, and being able to relax them fully in order to be able to contract them. Because it's just like our bicep. If we don't have full range of motion, if we keep contracting a shortened bicep, we're just going to end up with a really short, tight muscle. Exactly the same with the muscles in our pelvic floor. We're just going to end up with short, tight muscles.
And if you throw in a layer of complication like being post-childbirth, there could be some scar tissue in the area as well. After most surgeries, people are encouraged to do some gentle scar massage and things like that. That's something that's not always happening with vaginal deliveries, and so sometimes some of that scar tissue is actually like holding the pelvic floor, kind of being pulled in one direction or the other. All of these things are things that can be worked on one-on-one with you and your pelvic floor physical therapist or occupational therapist, because they can actually do, if you go to someone that is trained in pelvic rehab, they can do a very detailed internal and external assessment on your pelvic floor and give you personally very detailed feedback on any pulling of the tissues, any weakness of the tissues, any lack of coordination of the tissues, which is key if you want to make progress yourself, is to know very specifically what your pelvic floor is doing.
Right. So we zoom in to look at those details, and then we also, like Stacey was saying earlier, we take a step back and we zoom out. So we ask questions about sleep, about stress, about how your workday looks, like how do you sit or stand throughout the day, like when you move, are you holding your breath, like how are our pressure systems working, what's your posture like, are you able to stack everything, your pelvis on top of your rib cage? Do you like to hang out on your heels? So we zoom in and we zoom out and we look at the whole person, not just the pelvis, but that's part of that, when someone comes to see us, we like to kind of take that time to go through that really detailed intake and to educate. And I met with a lot of women who have said, wow, I didn't know that going every 3 to 4 hours was normal, or when it comes to bowels, like a lot of people, if in your family it's common for you to go, like if say your mom only went once a week, then what as being normal is once a week. The reality is that you should be having a bowel movement and it should be soft and you should not have to strain at least every day, and it does have a really big impact.
And that feeling of fully evacuating too. I have lots of patients that will say, oh no, I'm not constipated, I have a bowel movement every day, and then as we pull off layers and get a couple sessions in, they're like, oh yeah, but I never feel like I'm like fully empty. So you can still be having a bowel movement every day, and if you're not feeling like you're fully evacuating, or if you're having to strain to have that bowel movement, that is still in that category of constipation. And then that stool that's kind of caught in the rectum is pressing on the back of the bladder, making it so it actually increases the chance of having urinary leakage.
And then being able to fully relax those pelvic floor muscles, so in order to be able to get everything out, makes a really big difference. So again, pelvic floor dysfunction is a lot more than leaking. It can encompass, really the whole gamut of what happens, kind of, and it's not just your pelvic floor, it's kind of from, well, really, it's
the whole thing.
Yeah.
Your pelvis is the base of everything.
Right.
So that's kind of like, that's a lot of information really quick. We recognize that. That's kind of like pelvis is 101. But we would love to get into any topics that any of you that are actually here are specifically interested in, because we can talk for hours about pelvises, but if it's not somebody anybody cares to hear, we really like to, if we can, kind of focus in on anything. Does anybody have any random topics?
So if you had an episiotomy.
Yeah, so with an episiotomy, obviously there's going to be some scarring. And that is one of those things where even like I've done internal assessments on women that like, you know, they're like, oh, my kid's 40 years old, but we're still finding some tension around that scar line, and we still find that if you do some, you know, gentle release work around, and we don't love the word release, but it makes people know what you're talking about there.
Yeah.
If you do some fascial work around that scar line, you can still get a softening, you can still get an improvement, and that is, you know, a key area where a lot of women are continuing to have painful intercourse for decades after their episiotomy because no one's ever addressed the scar tissue.
Right. Or like difficulty with their bowels and bladders that have gotten progressively worse over time, you know, and things like, and a lot of the times you hear about medications or, you know,
well, and sometimes, like, okay, you had, you know, a couple of babies, you had that episiotomy, and you were trucking along just fine, but your pelvic floor was struggling and you never knew it, and then here comes menopause, and now those tissues are a little bit more atrophied, and now these symptoms are showing up. They're not coming out of nowhere by any means, but your body had just been able to compensate up until this point. But again, that doesn't mean that like, oh, I guess I have painful sex now because I had menopause. Like, there's so much that we can work on with the muscles, and then we can also work with, you know, talking with you and your doctor to see if maybe a vaginal moisturizer would be beneficial, or do we want to go as far as a moisturizer with that prescription estrogen? The moral of the story is if you have any complaints as far as like pelvic pain, bowel, bladder, anything like that, is that there's probably something that can be done.
Right.
To
You
help.
don't have to live with it.
You do not have to just live with it, which is what unfortunately a vast number of women are doing because they just don't realize that, like, oh, that's just not my life now. Like, and that's kind of the general response that I get from a lot of my patients is, well, my doctor said I should come here, but I don't know why. This is just, I had a baby, so I mean, I leak now. That's life.
Yeah.
So just kind of, no, let's not just accept that.
Okay, you said that you shouldn't get up in the middle of the night and go to the bathroom?
Nope.
Yeah, so again, there's lots of layers with that. So if you're getting up in the middle of the night to go to the bathroom, you know, one of the things that we would start peeling off is, okay, why? Are you waking up because you have that urge to urinate? Did it start with a pattern? So for a lot of my women, it actually starts when they're pregnant. Pregnancy is a wild card. All sorts of things happen. And then afterwards, you're nursing. And so, you know, one of the first things I tell my nursing mamas is, don't do those just in case voids at night. Like if you're getting up to nurse, I know a lot, it makes sense in your head and I get it, but if you're getting up to nurse the baby and then you get the baby back to sleep and then you're like, oh, I better go pee just in case because I don't want to have to wake up because of my bladder. You're already starting to train in that habit of getting up to urinate in the middle of the night. And then, you know, I've had some women that are coming to see me in their 50s and they're like, oh yeah, I've gotten up to pee at least once a night ever since my first baby was born. So like that's a hard pattern to break.
Right.
Well, I get up every night at like about 3:15, 3:30 every night.
Yeah, so it's like clockwork. So it's definitely something that your body has dialed into. So, you know, I would start asking questions along the lines of like, okay, what time do you go to bed? And then, you know, based off of what time do you go to bed, okay, what does your fluid intake look like throughout the day? Are you nice and even throughout the day, or are you like very heavy evening loaded?
Yeah.
Because I get a lot of people that, you know, especially if they're really busy jobs, like they're drinking like nothing during the day, and then they're getting home and drinking a ton of water.
Well, I drink water throughout the day while I'm at work with lemon in it and everything. And I go to the bathroom, you know, at work. At first it was like every thing of water I drank. After that, you know, I'm gonna say like an hour later, you have to go to the bathroom.
And how we drink, so there's two things when it comes to water. It's how much water we drink and how we drink it. So the rule of thumb is you should drink about half your body weight in ounces, and that's kind of like at a minimum. So if you're 140 pounds, you should be drinking about 70 ounces of water per day.
Okay, how much I should be drinking?
You gotta do the math.
Half your body weight.
I don't make any assumptions. So about half your body weight in ounces is at the minimum. If you know you have like a busy work day, if you have a lot going on, like we want to up that. But it's also how we drink it. Are you sipping it throughout the day, or are you chugging like, you know, 8 to 12 ounces? So if you're sipping, that's a really good habit to get into because your body can only absorb about 4 ounces of water at a time. So if you're like chugging 8 ounces of water, your body's getting the benefit of 4 of that, and the other 4 are just going to go right through you. So that's where you're going to get that. And your bladder's a muscle. It's your detrusor muscle. So it's going to get a sudden stretch and be like, oh, you gotta go. So you want to pay attention to what your daytime habits are because they do tend to drive those nighttime habits. So if you're like going to the bathroom every 3 to 4 hours during the day and you still find that at night you're waking up at that 3 a.m. point, do you wake up, like Stacey said, because you have to pee, or have you woken up and you're peeing just because you're awake? So then we'd go down like what's waking you up?
This what happens. Okay, this how mine do. I have to use the bathroom, but I say to myself, oh, I can hold it. But then a hot flash come. So I have to get up.
There's
So it makes me
another.
get
There's
up.
another layer,
Right.
another layer of the hormones, yeah.
Yeah.
So then you're getting up, and so then you're awake, so now you're out of that REM cycle. Now you're producing that, that daytime levels of urine. And that is something where, like, that's a whole nother talk, is about, like, managing hot flash symptoms and managing menopause and managing hormone fluctuations and all of that good stuff.
Yeah.
I would say the other thing to keep in mind too is if you're consuming any bladder irritants in the evening. So there's certain food and beverages that irritate the bladder lining, and so if you're getting up at night to urinate, and then we can kind of zoom out and be like that glass of wine before bed that you love so much, that might be triggering some irritation in the bladder. The other thing that we have to keep in mind is postmenopausal, our body processes alcohol differently.
I don't drink, so.
That's just one example.
Yeah.
So it can also be, anything carbonated, sugar. So basically, if it's not water, it has the potential to be a bladder irritant. And like in the evening is when a lot of people are, they're like, oh, I do good, I drink water all day, but then, I have my soda, my some teas or or something right in the evening before
And it
bed.
is very individualized. What is one person's bladder irritant may not bother another person. So that's why we often do a bladder diary where we actually get you to track like what you're eating and drinking throughout the day, when you're going to the bathroom, if you're feeling any urges, like if you're constipated, we'll have you track your bowels as well. And that gives us like a pretty good idea of what can be a specific, and from that information we build a specific plan.
The other question I always ask my people that are getting up at night is to start counting their urine stream. So anytime that you urinate, you sit, that urine stream starts, if you count 1, 1,000, 2, 1,000, 3, 1,000, the very, 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 very minimum it should be is a full 8 seconds.
Of like a nice, slow, steady stream.
Yes. Yeah, you shouldn't be pushing it out. It should not be like this power stream or anything like that.
No, don't power pee.
No power pee.
Apparently that's a
Don't
thing.
push.
Don't do it.
Yeah,
No.
don't do that. Yeah, apparently that's a thing that
What that do to you if you power pee?
it irritates the urethra, and how the mechanism of how urination works is that when those pelvic floor muscles relax, so you sit on the toilet, you're nice and comfortable,
Your
those
feet are
pelvic
flat.
floor muscles
You're
relax.
not hovering.
You're not hovering. Yes, don't hover. Those pelvic floor muscles relax, and that signals to the bladder that it's turn to contract.
They
Okay?
can't work together. Your pelvic floor muscles can't be on and your bladder can't squeeze at the same time. They have to work in opposites.
So if you're power peeing, people, how they accomplish it is actually by squeezing their abs, which creates a pressure,
On
which
top.
forces the urine out at a more rapid pace, but that causes urethral turbulence, or the urine that comes through the urethra really quickly agitates the urethral lining, which isn't comfortable. And then also, if your abs are contracting, because you have a lot of fascial connections between your abs and your pelvic floor, if you're contracting your abs, it's really hard to relax your pelvic floor. So even though that's not what you're going for, you're kind of creating this dyssynergistic pattern where the pelvic floor wants to relax to allow everything to evacuate fully, and instead it's like, am I supposed to be turning on? The abs are on. Oh, I'm so confused. It doesn't take much to confuse our bladders sometimes. So if you're getting up and to urinate in the middle of the night, and it's like, oh, I have this urge, and I get all the way up, and I hike all the way to the bathroom, and I sit there, and it's like drip, 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 and that's
Was
not a
not
real
true.
urge. That is something that we can actually just work on doing some urge suppression techniques and trying to get you to go back to sleep, because that's not even a true urge signal. Now, if you're getting up at 3 a.m. consistently, and you consistently have a full bladder, and you're not consuming mass quantities of fluid right before you go to bed, then we say, okay, why are you producing so much urine at night? Have you had a sleep study? Do you snore?
I'm eating some food and I'm drinking.
Yeah, and I don't ever cut cut people off. I'm not ever like, oh, 2 hours before bedtime, don't consume anything. But
No.
that's also like not the time to be consuming like mass quantities of liquidy goodness.
Yeah.
Especially anything that has a bladder irritant component to it.
So if someone was looking up like just pelvic floor exercises, is this something that they should do kind of on their own, or what's the benefit of hiring people like you?
So the problem is if you look up any pelvic floor symptom on the internet, you can look up anything. I'm having painful sex, I leak, I have to pee all the time. No matter what you look up, it's going to tell you to do 1,000 Kegels a day.
Yeah.
And most of the time, they've done some research where they've actually brought women in and tested their Kegels, and a significant proportion of women that were 100% convinced that they were doing their Kegel correctly were not.
Yeah.
They were either contracting the wrong muscles, or they were overcompensating, or they just weren't providing like a functional contraction and relaxation. So just getting that confirmation that if you should be doing Kegels, you're even remotely doing them correctly. But also, a lot of pelvic floor dysfunction, especially in our high stress, fast-paced lives, is actually more of a matter of tension than it is a matter of actual weakness. It's a matter of tension and poor coordination,
Right.
which is not the same thing as just lack of strength. So you can Kegel even correctly all day, and that's not going to change that lack of coordination, that lack of relaxation, and that lack of your ability to use the system as a whole. A pelvic floor alone isn't enough. You need to, be breathing, and your ribs need to move, and you should have good thoracic mobility, and all of that stuff plays into that pelvic floor dysfunction.
Yeah. So I think it's definitely worth taking the time to find like a pelvic floor therapist in your area, just to even start the conversation. I would say the majority, like your insurance will cover it. That's always a question is, does my insurance cover this? Yes, just like any
Most
other
of the time.
therapy.
Yeah, if you get any physical therapy or occupational therapy for anything and your insurance covers it, pelvic floor therapy is not any different. And Amy and I have, we have, the company's name is Health Elevated. We have a Facebook page that is probably the easiest way to get information from us. And we have multiple free courses on a platform called Teachable.
Yeah.
So the best thing to do is go to our Facebook page, and you can kind of see some posts, and you can message us and all of that stuff. And we'd be more than happy to obviously see you one-on-one if you're local here. Amy's at Spectrum Health Lakeland in Coloma. I'm at Northwest Health in LaPorte. We both see patients there via insurance. But also we recognize that like new moms and things like that, like sometimes it's just not an easy time in your life to get out of your house. So we have these teachable classes, which obviously is not the same thing as getting our hands on you and really feeling what your muscles are doing, but it's a great way for you to glean a lot of information from the comfort of your own home.
And we do offer one-on-one health coaching as well. So if you want to do it online, and like I said, getting out of the house is difficult, but you still have more questions, then we offer one-on-one health coaching too. So that gives you an opportunity to for us to go through like the things like Bladder Diaries and talk about like to zoom in, but also to zoom out.
Yeah.
There's a lot that can be done remotely too.
Yeah, the biggest issue with just the internet is it speaks in generalities and not even always 100% truthful generalities. But I always tell people, your history is going to be different than the next 10 histories I take. And so, Dr. Google can't take your history into account when it's coming up with a treatment plan for you and suggestions.
So what do you think is the most powerful thing that someone could have taken away from tonight's?
The most
workshop?
powerful thing for me always in my evaluation is to love your pelvic floor and be aware of it.
Yes.
So many women, if I say, can you contract your pelvic floor? Can you relax your pelvic floor? I just get a blank look. They have no idea where it is, what it feels like in their body. And you're never going to be able to make progress on a body part that your brain can't find. And you're also never going to make progress on a body part that you are purposefully mentally pushing away.
Right.
Like it is a part of you, it is helping stabilize you, it is helping keep things in and let things out, and just love your pelvic floor and have a good mental connection with it.
Breathe and drink more water.
Breathe and drink more. That's always Amy's point. Breathe and drink more water.